Kerry, before we expand a little bit on perioperative setting, let me ask you, you have a patient, you let's say gets EV Pembro in frontline setting in your clinic at UCSF. The patient does well, let's say I make it up, a year later has progression of disease. What do you do second line? Of course, clinical trials always comes to mind, but let's say in the absence of a clinical trial, what do you do and which parameters may shape your decision making?
Yeah, I mean, I think everything's gotten scrambled since we have this new frontline option of EVP. I think most providers would agree that platinum-based chemotherapy still has a role here. It's still effective and can, treat cancers. It probably doesn't generate the durable long-term responses as durable, at least for most patients, as we're seeing with EVP. I still think that is, without really good prospective data, that's still nonetheless our second line option. There are not that many other approved options in urothelial cancer with FGFR inhibitors for patients who have FGFR2 or 3 mutations. And we have HER2-directed therapy with trastuzumab deruxtecan, really in late line setting for any patient with HER2 3+. Those are sort of our major treatment options. Sacituzumab govitecan, as you showed at ESMO Asia, unfortunately was not successful in outperforming taxane chemotherapy in a randomized phase 3 trial, and the FDA approval has been withdrawn by the company, although it still seems to be available for some patients, and it's certainly available for patients with breast cancer. So whether or not to use it, I think is much more challenging, that type of decision making. So I am thinking about clinical trials for almost every patient who's refractory to EVP, and sort of going from there. I think if we need a quick response, I think platinum is the way to go. So if someone has EVP and is progressing in the liver, has spinal cord disease, has disease where really we need to get a benefit, then giving platinum is the right way to go. And I've given both cis and carbo in the second line setting, and I've seen responses to both. Cis, I think, is a little better if the patient's eligible to get it. But obviously we need better prospective data to tell us really what's right to do. There are actually some posters coming out. There were one or two at ASCO GU this year that sort of talked about response rates to platinum in the post EVP setting. But because this therapy is just being deployed worldwide now, I think we're just beginning to collect data about what's happening in post EVP patients.
Thanks, Terry. And I agree with you. Real world data can be the first read of what's happening in real world until we get some trials to get prospective data in that discussion and trying to optimize the sequence of therapies because, it's all new, as you mentioned, the last couple of years with first line Pembro EV. And to your point, we now have at least 2 targeted therapies for metastatic urothelial cancer, the revised FDA approval of erdafitinib as a regular approval for patients with activating mutation or fusion rearrangement for FGFR3 specifically, and also, as you mentioned, the HER2 IHC based on the gastric cancer scoring system 3+ for trastuzumab deruxtecan. Now, with this great discussion, and thank you all so far, it has been awesome. I want to pivot a little bit to go to a localized disease, and there's so much to talk about. Maybe, Matt, I will pick on you. I'll ask you to do something which it's easy for you, overall hard to synthesize a little bit the data of NIAGARA and CheckMate 274. You have been involved in both trials, just to get us going in how the data look like, and then maybe I will ask Christopher to comment on those data as a urologist.
So I think it's probably useful to think about where these treatment strategies differ and what's different about them, because they're not necessarily the same patients. So NIAGARA, of course, enrolled patients in the neoadjuvant setting, clinically localized muscle-invasive bladder cancer. Patients were randomized to 4 cycles of gemcitabine cisplatin plus durvalumab, followed by cystectomy, followed by 8 cycles of adjuvant durvalumab, versus 4 cycles of neoadjuvant gemcis followed by cystectomy with no planned adjuvant treatment. This trial did allow patients with a creatinine clearance down to 40. And if your creatinine clearance was 40 to 60, got split doses cisplatin. So it broadens the criteria a little bit, but technically not cisplatin ineligible patients in terms of those lower GFR. So for one, those patients wouldn't have been eligible for this study. 2, patients who go straight to cystectomy, which for better or worse, we still see frequently in our practices, even our academic practices, this treatment approach wouldn't apply to those patients. So those scenarios do apply to CheckMate 274. So patients enrolled in CheckMate 274 had neoadjuvant chemotherapy, mind you, without immunotherapy in the neoadjuvant setting, but had neoadjuvant chemotherapy, had pathological T2 or higher disease, in their surgical specimen, or did not have neoadjuvant chemotherapy, were cisplatin ineligible and had T3 or higher disease in their surgical specimen. So not exactly the same patients. With the neoadjuvant approach in NIAGARA, there was an improvement in event-free survival, one of the primary endpoints, and an improvement in overall survival, a key secondary endpoint. CheckMate 274 met its co-primary endpoint, showing an improvement in disease-free survival in the all-comer population and in patients with tumors with high levels of PD-L1 expression. Overall survival is also a secondary endpoint in CheckMate 274. It's an event-driven analysis. We actually haven't seen the final analysis yet. We've seen exploratory interim results that have been published now, showing that the effect size seems to be pretty similar and in the same direction as DFS, but we haven't seen an overall survival endpoint from that study yet.
Thanks, Matt. As expected, excellent summary. Christopher, what are your thoughts on this? From your urology standpoint overall, how does this totality of data impact your practice?
Yeah, I mean, I think muscle invasive bladder cancer is one of those really nice examples where multidisciplinary care really works and really benefits our patients. And I think, at an institutional level, everybody needs to sort out how they do it, but because there's a lot of handoffs, there's a lot of back and forth, and I think doing it well requires that integrated team approach and good communication. But I think we really get the optimal outcomes when we do that. So for me, it's a really nice approach. I think, post-diagnosis, you want to send to your medical oncologist. I don't feel prescriptive about regimes. I really think it's not our role. In our sort of practice environment, our neoadjuvant use is probably in the 60+% range. So I think we're currently doing quite well. There's obviously a reasonable subset of patients who are cis ineligible. You still see those in the older muscle invasive bladder cancer patients, and those patients, our urology guidelines tell us that if there isn't a trial, they go straight to a cystectomy. And so, thinking about these two trials, there's clearly a subset of patients where an upfront cystectomy is, I think, a very reasonable and very appropriate thing. The other sort of, the other consideration then is when you are giving neoadjuvant therapy, everyone likes to have, some tailored response. And so the idea of being committed to adjuvant, I think, is going to be very interesting as we roll forward into real world practice. And, patients who've had good pathological responses to their neoadjuvant chemo IO, are they that keen for the 8 more cycles of durvalumab, or do they want to, maybe, especially if ctDNA is available, maybe take their chances with omitting the adjuvant phase? And I think as we move into actual practice, that's really interesting. And the other sort of last thing I would say is that these are surgically grounded trials, but there's such a role for trimodal therapy and bladder sparing approaches that don't rely on cystectomy. And so the data is a lot less clear, I think, on how we manage the, peri-local therapy, as it were, for the patients who opt for trimodal, and thinking about what the right, way of giving the systemic therapy around the time of that, chemoradiotherapy for the local treatment.
Thanks, Christopher. Great points. And obviously, all of us, I think, will echo our hope for the future to do more bladder preservation for our patients, and could identify patients who could be cured with systemic therapy alone or have long-term remission. That's the active pursuit on many trials. And, Matt and Betsy have done many efforts in that regard.